Welcome to Your Health Matters with Dr. Benjamin Bryant, Chief of Staff and General Surgeon here at UH Conneaut Medical Center. As we record this, we're about, 24 hours away, Doc, from our first major snowstorm?
Oh, is that right?
Yes. And you live on a lake, I live by the lake, and I guess we're supposed to get a lake effect storm Thursday night through Saturday, I think it is.
And we had a little bit over the holidays.
Yeah, a little bit.
And that's so that you noticed it on the roads, but it wasn't major.
No.
Oh boy, here we go.
It's time. I think we're due.
Yeah, I think we are.
You have a guest this morning.
Well, I'll tell you, we're really pleased to have Olivia Falcone join us. Olivia is with the speech therapy service here at University Hospital's Conneaut Medical Center. And we're going to go in today exactly who she is, what that is, who comes to see her, what goes on. I was told by one of the administrators here at the hospital that this service, speech therapy, has a potential impact, a positive impact for a lot of people. So we want to make sure people understand it, know what it is, and what it's about. So Olivia, what is speech therapy?
So speech therapy involves not only giving therapy for speech sounds, so articulation, the way sounds are said, but also language, swallowing disorders, stuttering, voice disorders, even memory, and sometimes reading. So there's a lot that we do.
How did you get involved in this?
Well, I went to school for speech therapy, and then,
So you always wanted to do
yes,
that?
I've always wanted to do something in the medical field and something to do with education. So I think speech therapy is a great in between. So.
Where'd you go to school?
I got my master's from Edinburgh University in Pennsylvania, and then I got my bachelor's from Kent State.
Okay, very good.
Great. And how long have you been here in Conneaut?
I just started here at Conneaut in October.
Wow. Okay. Great. Great. Well, it's great to have you.
Thank you. It's great to be here.
I am going to sort of launch right into how this impacts my practice. Okay? Because it's not uncommon for me to have someone come in who they have a swallowing problem. Okay? Now, by far the most common is, gosh, you know, when I go to swallow a pill, sometimes it gets stuck, or sometimes when I go to drink water, it's really hard. That's very different than someone who says, oh yeah, you know, I eat something and it feels like it hangs up down here. That's a whole different story. Okay? That's usually something that's in the esophagus. That kind of symptom gets our attention real quick because it can mean a narrowing of the esophagus. There's lots of different reasons why that can happen, some of them not so good. So we always want to, you know, check that out with an endoscopy. But the upper ones are much more common. And it's kind of a gray area. What I mean by that is several different disciplines overlap in that area. Okay, feeling up here, it's hard to swallow, it feels like it hangs up. I just can't seem to do it right. Sometimes I cough. All right. Well, that can be from reflux. That can be from reflux. If the acid's coming up and just really irritating that area, it can produce that kind of sensation. It can also be from an ENT kind of problem, something going on with the tissues in that area. There can be a kind of a narrowing. There can be inflammation that's from an ENT source. Neurology also impacts on that, coordination of the swallowing muscles. So it can be a little bit tough to sort that out. And a lot of times, you know, I have to do my part and I'll make sure that it isn't reflux related. Okay, fine, so we can eliminate that, but then we still have the problem of figuring out what's going on. That's where speech therapy comes in.
So it's really important if you're having any difficulty with swallowing and coughing or choking when you're eating, because that could mean that something is going down the wrong way and possibly towards the airway and towards the lungs. So you'd really want to see a speech pathologist to do an evaluation to see what is really going on, if the food is traveling the wrong way. And one of the ways that we can determine this is a modified barium swallow study, which is an x-ray that allows us to see what's happening while you swallow.
So the doctor's office will order a modified barium swallow. That's what they'll order. Okay? And the patient comes in, and what happens?
So we give them a couple different things to eat and drink. So some of the things are thinner, like the liquids, and then some things are kind of like more food and texture, just so we can see a variety of different things. And then we'll have you eat and drink, and an x-ray will be going on so we can see what's happening.
So what they're eating and drinking shows up on the x-ray?
Yes, and it shows up on the x-ray, so there's barium mixed in. And it doesn't taste too bad. I've tried it before, and it's really not too bad. It's pretty painless.
It's not as bad as it
No.
used to be chalk. I mean, it used to be horrible.
Yeah, they flavor it now these days, and
They flavor it.
it's a pretty quick test, so it's really great.
So you're actually swallowing, and then it's fluoroscopy. They're actually watching in real time.
Yes,
Okay.
yes, and it does get recorded, so sometimes, we will go back and watch, or sometimes I'll even show them to patients so that they can see what's going on, because a lot of people, they really want to know.
So, Olivia, you're not teaching people how to get rid of this. You're actually kind of like diagnosing it?
That's a great question. So that's the first step. Our first step before we provide treatment is an evaluation, so figuring out what is going on, what's the problem. Then the next step, the treatment, then we'll select different treatments. So if we're going to strengthen it and go that route, so strengthening the muscles, or if we're going to teach them some strategies, so maybe different positioning, things like that, or if maybe we're going to make some recommendations for diet consistencies. So that's usually the last route that we would go. We usually try the first two.
Okay.
So what are some of the things that you see on the study?
On the study, sometimes we can see if there's reduced movement of the muscles. So we really like to have a study done so that we know which muscles we want to target.
Now that might be something that could be seen after a stroke.
So, yeah, sometimes after people have a stroke, it can impact the way those muscles in the throat work. So that's when we would also want to look at different positioning, because there's research to show that depending on if you have a left side or right side impairment from a stroke, there's different positioning that we would like to see under the fluoroscopy to see if that's effective for you and if that's a strategy that we'd want to use.
You know, Doc, this is actually the first I've heard of this particular thing being done here at the hospital. I think it's wonderful.
Oh yeah,
It's
God.
great.
It's great for us to have it for sure.
Yeah.
You know, you wouldn't. This is not the kind of thing you just in your daily life would come in contact with.
Right.
But if you have that kind of a problem, it's really something that you want to know about.
Sure,
Mhm.
sure. You know, Olivia, a lot of people, a lot of parents get worried about their children if they are late talkers.
Mm-hmm. That's correct.
And I've known a couple parents that have been concerned about that. Would they come to you with this?
Yes, that's a common concern that we have. And I do like to tell parents a general rule of thumb, most children do begin to say their word around 12 months. Now that doesn't mean every child is going to start talking at exactly the same time. That's just a good rule of thumb. Usually around 2 years, that's when a child will start to put 2 words together. So if a parent is concerned, I would urge them to see a speech therapist to do an evaluation to see whether their child would be a good candidate for therapy. And there's a lot of strategies and techniques that we like to teach these parents so that they can help their child at home and get them talking sooner.
Would the concern start at a child's 2 years of age?
If the child is 2 years old and not saying any words, then I would definitely say yes, get them in therapy and
Okay.
see what kind of things we can do to help them.
Okay. What are some of the things that you would do?
So we like to see if the child is attempting to communicate. So we'll go through and do an evaluation, see if we can get them to communicate and try a couple different strategies. One of my favorites is setting up the environment. So you maybe give them something that's hard for them to open and kind of waiting it out and seeing if we can get them to try to communicate.
Okay.
So.
Very good.
I think an important point here, parents, is that you're not alone in this.
Mm-hmm.
Okay, it can be frightening. It can be a source of a lot of anxiety, and it may just be normal and you don't know it.
Definitely.
My oldest girl did not say anything until she was over 2 years old.
Really?
Yeah, and then she started speaking sentences and she never stopped.
Well, being a doctor.
So
To
sometimes
this day.
they do catch up, like you're saying, yes.
Being a doctor, were you concerned?
Well, I wasn't a doc at that time.
Oh, you
That
weren't?
was a long time ago.
Oh, okay.
Yeah, we just thought, gosh, because she seemed, very bright and responsive. She just didn't say anything. And then one day she told the dog to get out.
Really?
She told the dog to get out, and then when it,
There
like
you
I say,
go.
it's never stopped since.
Great.
But it would have been reassuring to us because we did not know what was going on.
Yeah, right.
And it turned out that was a normal variant.
Okay.
So getting the information can be very reassuring for parents.
Mhm.
Getting help for the kids early can be important.
Mhm. And sometimes what we'll say is we'll monitor and maybe bring them back in, 3 to 6 months so that we can see, if we're not that concerned. And if the parent isn't sure if they want therapy, sometimes we do monitor, like what you're talking about.
What's the difference between speech and language, Olivia?
Speech is the way that our sounds are said. So an example of this would be if we work on producing the sound R with a child, so getting them to say language is how we communicate. So an example of this would be getting a child to request something with words instead of just pointing.
Okay. Which they do.
Yes.
They do that.
Yeah.
So if they could have both problems, speech and language?
Yes, and that is common, and what we will do then sometimes is treat both of them in the same session. So we'll incorporate both, so trying to get them to use language more and using strategies to help that, and then also targeting different sounds.
Okay. Okay. Interesting. What about autism? You help children with that?
Yes, we do. A lot of times children with autism might have difficulty communicating, getting their point, wants, needs, thoughts, feelings across. Sometimes it's hard for them. And when it's hard for somebody to communicate, we might see some negative behaviors. So if we help them communicate and give them the skills that they need, help them to understand and use language, a lot of times we'll see decrease of those negative behaviors. And parents will say, wow, it's like a different child.
Yeah.
So we really need to help these kids communicate, and we also help them by giving social therapy, so helping them to use communication in different social settings, and that can be really beneficial to children with autism.
Excellent.
Absolutely. Now here in our community, what are the most common things you see?
So we actually see a wide variety. The most common, I would have to say, there's a lot of children that we see for language, so they are just not talking as much or the same way as their same age peers are. And then a lot of people also we see for swallowing problems, whether those are inpatient, so people in the hospital, or people who come to outpatient for swallowing therapy.
So those are the most common ones.
Those are the most common, but like I said, we do get a wide variety.
I was in a restaurant a couple weeks ago, and I noticed there was a gentleman there that was having a hard time speaking, and I think he had a stroke.
Mm-hmm.
And can you bring that back? Can you bring the speech back, or can you help him so you can understand him a little better?
So there are different things that we can do to help people after they've had a stroke. So we can give language therapy.
Okay.
So what we would do is we would assess how are they using language. Can they understand language? Are they able to find words? Really pick apart where are their problems, and then we would devise an individualized treatment program. And then when we give language therapy, that actually strengthens those neural connections in the brain, so to kind of bring some of that back. So sometimes we aren't sure what kind of progress we're going to see, so that's really hard to say, but it's definitely, there's definitely good research to show that language therapy is helpful following a stroke.
That's great.
Mm-hmm.
That really is very, very important, and it's got to be encouraging to people out there to hear. that it doesn't necessarily have to be stuck at its worst, all right? That you know, it's worth a shot, and a lot of times there are good results from it. Because that's such a devastating thing. When that
Yeah, it
happens.
is. It really is. You mentioned, Doc, I think, might have mentioned barium treatment. What is a modified barium swallow study?
So yeah, a modified barium swallow study is when somebody is placed under the x-ray. So you go in and they do an x-ray while you eat and drink different things that contain barium. So the barium allows us to see where it's going, if it's going towards the lungs, or if it's going down the esophagus the correct way.
And modified just means different things, different consistencies.
Right, the different consistencies. So we'll modify that. We'll start with something that's thin like water, and it can go all the way as thick to something like pudding. We can take a graham cracker and watch a graham cracker go down if we put a little bit of barium on it. So we modify it to the patient. So I think that's where that name actually comes from.
Olivia mentioned earlier, and I just want to emphasize this point, people who are having these kinds of swallowing difficulties, it can indicate that liquids, even solids, are going into the lungs, even a small amount, okay? Not a good situation. That can lead to terrible pneumonias, terrible infections, especially if it's chronic lung damage. Okay, so it's something to take seriously. And the modified barium study can show whether that's happening, how great the risk is. Because if that's happening, you want to know it, so you can do something about it.
Let me, because I'm not a medical person, but, so you're swallowing, it can go into the lungs?
Well, the opening to the esophagus and the opening to the windpipe are right next to each other.
Okay,
And the physiology, the functioning,
okay.
that when you swallow that makes it go to the right place is very fancy. Okay, very fancy.
That's true.
There's many different muscles involved, and they all have to contract the right amount and in the right sequence.
Wow.
You see, we never even think of it; we just do it.
Right.
It's a reflex.
Right.
But what's actually happening there is all these different muscles are contracting to varying degrees in exactly the right sequence to make that happen properly.
Okay.
And there are things that can throw that off. Stroke certainly can. There are other things that can do it too. There's other neurologic problems. There can be problems with the actual tissues there that make it more difficult. And so it's you know, there's a lot of moving parts. And when there's a lot of moving parts, there's always room for mischief, you see.
Okay, I never knew that.
Yeah.
Never knew that.
Yeah, there's a lot of people that don't know how important it is for swallowing to occur properly so that it doesn't go down the wrong way towards the lungs.
Did you have a question, Matt?
Yeah. Does a patient or a parent need a pre-authorization from a doctor to come and see you?
Yes, that's a great question. So a lot of times we will call the doctor's office, or we will have the patient call the doctor's office and ask for a referral to speech therapy. And then once we get that referral, we would get their insurance information and make them an appointment.
Okay, so you got to get the ICD-10 from the doc's office. I mean, you got to get the referral from the doc's office.
Yes, we do.
Right.
Mhm.
Okay.
Well, now that we're on that subject, what are the steps, what are the procedures that a patient would have to go through when they come to see you?
Okay, so before we would treat a patient or evaluate a patient, we would have them contact their doctor, or we could contact their doctor. So we'd get an order. So the doctor would want to write an order that the patient needs speech therapy. So a lot of times, you know, parents, you can just tell your doctor, I'm worried that they aren't talking, or I'm worried that they aren't saying certain sounds right. So you can go ahead and get the order that way, and then the order then is faxed to us, and then we will contact you, or you can call us to schedule an appointment, and then that way we'll get all your insurance information and everything set up.
Now, you're based out of UH here, right?
Yes, that's correct.
And where's your office at? I mean,
Yeah, our office is in the rehab department, so that's on the 3rd floor.
3rd floor.
Mhm.
Okay. And you mentioned insurance. Would the insurance cover this?
Most times, insurance does cover speech therapy, so it's important to just check with your provider to get those specific details. And our office will ask for your insurance provider and all of that, so we'll look into the details before offering any services so that you know.
I have a personal question to ask you.
Sure.
My wife, she'll probably kill me for saying this, but she cannot take pills very well. And she has to take them one at a time.
That's very common, Pat.
Is it? And she does, like, she'll take her ibuprofen or whatever, and it's like a procedure to watch her go through. And she goes, I've been like this all my life, you know, so is there something that can be done about that, or is that just the way it is?
So like the doctor said, that is very, very common. So just a couple suggestions that I would have for her would be to make sure she's not swallowing these pills on a dry throat. So make sure she's really hydrated, drinking water before she attempts to take the pills.
Okay.
Another thing too, sometimes putting the pill in applesauce. That is sometimes helpful. It kind of helps it slide down and gives it the push that it needs
It's
to
really
go
true.
down.
It's really true.
Really?
Oh, yeah.
Mhm. So if they're causing too much of a problem, then sometimes the applesauce trick is a good idea.
Okay, thank you.
You're
Appreciate
welcome.
You know, a lot of times pills, if they're too big, you can
Yeah.
break them in half.
that. Okay.
Capsules, not so much, but if it's a solid pill,
Yeah,
breaking it in half doesn't hurt anything.
okay,
Mhm.
okay.
But she's absolutely right about that applesauce. I've had patients who, it's like, whoa, completely solved the problem.
Is that right?
Oh, yeah.
Never heard of
Yeah,
that.
I think the weight of it kind of gives it the push it needs to go down. It
Mhm.
kind of triggers the swallow.
Yeah.
You know, years ago, I had to take that barium thing. You know, I can't remember. I was having stomach problems or something, and they made me drink that chalky stuff. They didn't have flavors to it then,
Oh,
Doc.
man, that was horrible.
It was horrifying.
I have had patients complain.
Oh, Lord. But I think and then they did x-rays and stuff. Do you have to go down the throat?
So no, this is a very minimally invasive procedure, and a lot of people who have had GI studies like you have had in the past had to drink a lot of barium prior to the study. Is that correct? You had to drink a whole cup.
Yeah,
So
yeah.
that's not what a modified barium study is like with speech therapy. It's really only looking at the neck and the esophagus. So just the very top of the esophagus. So it isn't going to pan down and look at all the GI things. And you don't need to drink a ton of barium before this. You're actually drinking small amounts of it during the test. So we don't have you drink a large amount before, like a lot of people who've had some GI tests or esophagograms think that they need to drink a lot, a full cup of it, and that's not how it is with a modified barium study.
How long would a procedure like that last? I mean, how long would they be in your office?
Sometimes it can take a little while to get the positioning and everything like that and set up. So, but during the test usually doesn't take any more than 5 to 10 minutes.
Oh.
It takes longer, you know, signing in with radiology,
Right.
getting in the chair, getting positioned, everything set up than it does the actual time that they're under the radiation.
Gotcha. Okay.
Now, once that test is completed, where does the information go?
Good question. Yeah.
So the information is then recorded, so sometimes I will go back and rewatch before I make any recommendations.
The doctor gets a copy of it.
Yes,
But-
the radiologist does get a copy, and he will usually write his own report then also. And then I write a report also of the findings, so if there's any impairment and what those specific impairments are, if I would recommend treatment, if so, how often, what type of treatment I would recommend, and what kind of diet most importantly. So did I see any aspiration with certain consistencies? So things like that. And then I like to give that information to the patient the same day so that they know what's going on, what happened, and give them recommendations right then and there.
A lot of people have, like Doc has mentioned, we've talked about it a lot of times, have these problems with acid reflex. And you know, if I eat, I have to take a tablet, like if I'm having spaghetti later in the evening, and I could wake up in the middle of the night really sick.
Okay, sure.
Is that okay to do? Is to take an acid pill or anti-acid.
Right, so your doctor is gonna make those recommendations on how to manage the acid. And now what I would usually tell patients are just some precautions for GERD or reflux.
Mhm.
So definitely eating upright. And then I like to ask people to remain upright for 30 to 45 minutes after a meal. And so what remaining upright does, it allows everything that's in the stomach and the esophagus to stay down. We don't want to encourage any of that coming back up.
Mm-hmm.
So that's definitely one recommendation that I will always tell people with GERD precautions. Make sure that you're staying upright following your meals.
No nap right after eating.
No, as much as you want to, try not to, because it can kind of encourage that reflux to come back up.
Okay. Okay.
And also eating slowly. Eating slowly has helped people with acid reflux. So there's reasons why eating slowly helps that. And it's something that we see helps people. Taking smaller bites. I think when we eat too fast and the esophagus is forced to open and close really fast, we see problems later on with GERD after the meal. So,
Really?
yeah, so eating slowly sometimes can make a big difference for
Okay.
certain patients with GERD.
Because I've seen people, I don't know how they can eat so fast. I'm a slow eater, but I've seen people, they're done long before I am.
Mm-hmm.
I don't even understand how they can even digest that. It just,
Mm-hmm.
just seems like a bad habit.
Right, it's a good idea for anyone just to eat slowly
Slow.
and take small bites.
Okay. So again, the insurance, it does cover this for the most part.
Most insurance will, and it just depends on your provider how much or how often, and we'll work with you and let you know if you have any questions or anything
And we're,
like that.
say Medicare, that would
Yes.
part of that same thing?
Yes.
Okay. All right.
Yeah, generally what the departments like speech therapy, they have people whose job it is to look into this and
Mhm.
coordinate the benefits and so on. So
Mhm.
it's known and it's communicated to the patients up front.
Okay.
Mhm.
Yeah.
Good deal.
So you're available 5 days a week?
Yes, we offer speech therapy 5 days a week. I am here Mondays, Wednesdays, and Fridays, and there's another therapist here on Tuesdays and Thursdays.
What are the hours?
So we offer a wide variety of appointment times. Wednesday we actually offer even later appointments, so I'm here until 6:30 on Wednesdays.
Okay.
Mm-hmm.
And you see both inpatients and out. You do
Yes.
inpatient consults?
Yes, we see inpatients as well, and sometimes when these people they get better, they still come to see us as outpatients to kind of
So
get
that's
all
a
the way
nice
back.
transition.
Yeah. It's a nice transition because they
Sure.
get to stay with the same provider and kind of continuity of care.
Now, see, Denise Brown, who we've had on this show in the past with the hospital-to-home program, she would pick up on that. See, she
Mhm.
would pick up on the fact that the
Right.
patient had that while in the hospital,
Mhm.
make sure that that was all set.
That's right, yeah,
You
yeah.
know, and then at the home visit, did you get to see the speech pathologist and like that?
Yeah, another good service that UH offers to the patients out there.
Yeah. Yeah, I was just at the annual UH Docs meeting last night in Cleveland.
Mhm.
Big meeting,
Mhm.
a lot of, and one of the things that was presented was the response from the public, from the patients, in terms of patient satisfaction, which is a buzzword, but it's also a very important word.
Mhm.
I mean, it's patient satisfaction. Did you have a good experience when you went to were in contact with UH? Did you have a good experience with your doctor as an outpatient? Did you have a good experience with the hospital, the different departments, that sort of thing? And there's an imperative, from CMS and those kinds of places to emphasize that. But UH was way out in front in terms of
Good.
picking up on it and emphasizing it early on. And the scores that UH is getting are just phenomenal.
I think Doc and I have been doing this for quite a while, but is it 8 years? 8 years. Wow. I know we did a whole show on, we had some of the staff here come in, and they were very stressful on getting good patient remarks on their stay in the hospital.
Mhm.
And we did a whole half an hour on that.
Oh, yeah, hospital takes it very seriously.
Yeah, very much.
You know, and being able to provide this kind of expertise to the community is a big part of that.
And that, you know, another reason we do this show is to inform people what UH does offer. And like I said, I had no idea that we had speech therapy here. I had no idea at all. So.
And it's relatively a newer program that we've had. So
Okay.
within the last couple of years, it's a newer program that we've had here. So it's great to get the word out and let people know that we're here and we're taking new patients.
Do you live in Conneaut?
No, I don't.
No?
No, I live in Menor, Concord area.
Menor? Okay.
Yeah, so it's a little bit of a drive for me.
Sure, especially in
Yeah.
that bad weather.
Yeah, but it's the opposite of traffic, so it's not too bad.
Okay, that's good.
Yeah.
That's good.
Yeah.
Yeah, well, exactly. I think it's very important for the public to realize who you are and what this is, because there's, you know, so many people out there with swallowing problems, and you don't just have to live with it. You know, you bring it up to your doctor, and your doctor will send you over, and then you start getting real help for it.
Mhm.
Correct.
You know, your kids speaking, your own swallowing problems, very, very common things. Now, I hope our public understands that there really is something that will benefit people who have these kinds of issues.
Absolutely.
So, and we have it right here in our small town. It's amazing.
Excellent. All right. Anything else you want to cover, Olivia?
I think we covered it all.
Okay.
Yeah.
Well, listen, we really appreciate you taking the time to come by and talk with us and talk to the public about all this.
Absolutely.
Of course, thank you for having me.
Okay.
All right. And you have a Merry Christmas.
Thank you as well.
Thank you. And folks, if you have any questions for us here at Your Health Matters, get a hold of Dr. Bryant. The numbers are going to be on the screen, and it's also 599-7640. And he'd be glad to address those.
Absolutely, absolutely.
And we have some other guests coming in for the rest of the month, too, to finish out the year.
That's right. Next week, Denise DiDonato is going to be coming in to give a recap of what has happened at UH Conneaut in the past year, the programs and the staff and so on,
Mhm.
and also a preview of what's coming up in 2017.
Great.
So that'll be a really interesting show. And then on the 28th, Dr. Mata, excuse me, our new pulmonologist, and intensivist, who were very, very excited to be here, and he's going to be interacting with Olivia, certainly, because his pulmonology discipline certainly overlaps with hers.
He's never been on before, has he?
Well, he just got here.
Oh, he did?
He just got here.
Okay, cool. That's great.
Yeah, so he's going to be on and introduce all the new programs, very exciting, significant new programs that are available in our town now that he's here.
Excellent.
So he'll be joining us as well.
Looking forward to that.
And again, I always make this plea, if you have any questions, related or unrelated, any questions that you would like us to cover on these shows, please let me know, please let Pat know, and because we've had a couple shows recently where we addressed those, and we really welcome that. That's why we're here.
Absolutely. Folks, we want to wish you a great week, and we'll see you again next week.